Well, hello, everyone. Thank you for joining us today for OneLegacy's second virtual town hall discussion, connecting the dots and engaging our community. Our virtual town hall series is set to provide knowledge, empowerment, and address health disparities in the diverse communities we serve. Connecting the Dots is a platform we have created where you can hear from experts in a specific field, and the experts can also hear from you. This is an opportunity to engage in meaningful conversation. My name is Tiffany Jones. I am part of the One Legacy Public Education Department, and we are the front lines of educating people about donor registration and awareness. Today, we are using our platform for a much needed conversation. We'll be discussing the HOPE Act. We will be joined by Brianna Doby, donation community consultant, Dr. Bencheqron, also known as Dr. B, pulmonologist and critical care specialist, and LGBTQ plus rights advocate, Aaron Cohen, manager of donor allocation from OneLegacy, and Nina Martinez, the first ever living HIV positive donor, kidney donor in the United States. And if there's nothing else, I am turning it over to you, Dr. B.
Thank you, Tiffany. Hi, everybody, and thank you for joining in. I appreciate OneLegacy for having put together this panel of experts and advocates. This is a very important issue where we want to discuss organ donation from the different populations and how we can improve the donations. And the HOPE Act has actually done just that. To get started, I want to invite my co-panelist, Brianna. Hi, Brianna.
Hi, Dr. B. How are you?
I am doing well, thank you. I hope you and your loved ones are safe.
We are, thank you. And I see that beautiful view behind you, such a California view. It's so nice, so nice to see. I sure am thinking about you and your patients and your family as well.
Thank you. I want to engage this conversation by at least knowing what the HOPE Act. If I were to Google the HOPE Act, the one that comes out is the HOPES Act, which is the stimulus that came out during the COVID. I don't think that that's what we're talking about, is it?
It's not. We have a little bit of an SEO issue for any of our friends in internet parlance. But the HOPE Act was actually passed in 2013, and I know this will surprise you, Dr. B, but it was bipartisan. Essentially, there was no objection from either Democrats or Republicans, which is kind of crazy to think about in today's world. But it was signed into law by then President Obama. And what the HOPE Act made possible was something that is really, really important. And it's that people living with HIV could register and volunteer to be organ donors under a research protocol, because there are patients living with HIV who are also in end-stage organ failure, as I know you are very well aware, that need transplants. And this was a special donor pool to make sure that people living with HIV, before they could receive a transplant from someone who didn't have HIV, from an HIV negative organ donor, but why not allow people living with HIV to save lives as well, because we could manage HIV within transplantation. So it's a really cool update clinically, and we're almost at 200 transplants now since the HOPE Act was passed.
That is amazing. So just to put things in perspective, I wanted to discuss how many people are on the transplant list in the United States. I think I have looked up some data, but do you have any fresher data than I do?
Sure, the number fluctuates anywhere from like 110 to 120 to 30,000. It changes, right?
Wow.
And it's a lot of people who are waiting on that life-saving gift. And you can actually blow it out even farther than that and say, you know, there are people who are living on dialysis. I think in California alone, there's 120 to 130,000 patients right now with end-stage renal disease. right? So their kidneys aren't fully functioning, they're on dialysis or they're on other therapies. Those might be people who could benefit from a kidney transplant. There's also in California about 95,000 people, between 90 and 95,000 people living with HIV in California. So, there's a great need for organ transplants. There's also about 1.1 to 1.2 million Americans living with HIV in the US right now.
Thank you so much. Nina, I want to bring you in the conversation and share with you your view on how did you get to be part of this conversation of organ donation?
Sure. Well, most people who end up as living donors tend to know somebody else who has also donated. And in my case, I saw it on television first. There's an episode of Grey's Anatomy where they actually do demonstrate that there's a living HIV to HIV transplant before we ever did the first deceased donor HIV to HIV transplants in March 2016. That episode of Grey's Anatomy aired in the spring of 2014. So when the HOPE Act was passed, I was 30 years old. I was just coming to terms with the rest of my life with HIV. I had been diagnosed at 8 years old, had acquired HIV through a blood transfusion at 6 weeks old in 1983. So I was in need of blood to save my life. My life was saved by a blood donation. And then when the HOPE Act was passed, I was 30, but most of the conversation was around deceased donation. And that was not something I was ready to think about yet. But when I saw, somebody demonstrate on television the idea of living donation, to me, that was something that was really appealing. And then a former neighbor of mine the following year donated as part of a chain. So she was a non-directed donor. And I thought to myself, well, look, it's legal for me to donate now because of the HOPE Act. So it was something that I held on to, but it didn't really become real to me, as it doesn't to many people, until you know somebody who's in end-stage renal disease or end-stage kidney disease. So I had a friend who said, hey, I'm in stage 5 kidney failure, I need a kidney. And generally, because it hadn't been done before, I normally wouldn't think about, oh, he's talking to me because I'm living with HIV. But I am the kind of person that will step up and I connect the dots. And I was like, I still want to donate. Let me see if a general internet search on studies will come up, because maybe we're there now, as we weren't in 2016. We weren't with living donation yet. So that's actually how I found Johns Hopkins. And I reached out and I said, how do I get evaluated? I'm in fairly good health. I'm confident. I've been clinically followed. My viral load is undetectable, which means that the level of virus in my bloodstream is so low that it can't be detected on a lab test. I'm in good health. I run marathons for charity. Not that I like running. I think running is like flossing. It's good for you, but not necessarily enjoyable. But I will do it for a good cause. And honestly, I just wanted to be able to help my friends. So that's same as anybody else not living with HIV. If you know somebody, if you know someone who's donated, it makes that medical decision a lot easier to make.
That's pretty inspiring. I think I was, I loved you from the first time I met you virtually. And I wanted to bring about, why is this issue so important and why is everybody involved in it or should be involved? I came about to the arena of organ transplantation because I basically said to myself, well, at first, I'm taking care of all these patients and I'm talking to their families and I'm just saying to them, they need to let their loved one go because there's nothing that we can do. And then one of them mentioned to me, he wanted to be an organ donor. And I started my relationship with OneLegacy at that time, where I got educated, I think a decade ago now, about how much this is so important, because we all think that, well, medicine, it's 2020, so we ought to be able to have organs to give to everybody. It's not so simple, unfortunately. And I like to remember I think he was in Latin America, this multi-billionaire that made the news worldwide by wanting to bury his Maserati right next to where he would be when he dies. And then it made the news all over the world. And then on the day of, everybody was asking, why are you doing that? and he got on the microphone and talked to the world and says, everybody buries organs that are much more precious than my car every single day, and nobody bats an eyelid. So I think it's very important to know that there are people that are awaiting for that life-saving donation. And the science is not growing quick enough to replace some of these in order for people to have life-saving organs. So at this time, I want to turn it to Brianna and share with me how many of these maybe organs that, or at least on the waiting list, that are perhaps children. I think that we forget that there are around the world people that need to be saved and they have a life ahead of them, but they have a life-threatening diagnosis. I heard something around the waiting list has over 2,500 children or something like that.
That sounds about right to me, Dr. B. And the best place to get those statistics that are up to the minute accurate is at unos.org. And UNOS is the contractor that is funded by the federal government. And their job is to have a list of all of the people who are actively awaiting transplant. And the cool thing about their website is they offer real-time information about who needs a transplant and who is listed. So it's unos.org, and I believe there's actually a link from the OneLegacy website where you can also see that as well. And the cool thing about that too is you can look at how many people are waiting in California specifically. So you can drill down by state and say, this is how many people need a heart or lungs or a kidney transplant in the state of California. One thing that I did want to note is that Nina, who Dr. B, I'll fight you for her. I knew her first. She's mine. She's lovable in all the ways that Nina is lovable, because she does extraordinary things with a quiet strength and power that I admire very much. I'm making her uncomfortable right now, which I like that too. But one of the things that Nina said about her incredible good health, right? So Nina is incredibly healthy, as living donors are, right? Like, to be able to give a kidney, to be able to provide that gift of life, you need to make sure it's not going to harm you, right? That you're healthy enough to give that gift. But I do want to say to the audience broadly today, whether you're an ambassador from OneLegacy or you're in the clinical work, a lot of times people rule themselves out for organ donation because they believe they have to be as healthy as Nina. So I just wanted to say to you as a clinician as well, we have had treatment naive donors. So people who did not know during life that they were HIV positive because they never got tested. They have been able to be organ donors. We've had people who were in and out of care who have been able to be deceased HIV positive organ donors. And also that, maybe their viral load is different than Nina's. U equals U, as we know, but really high levels of viral control are not necessary for someone to be able to be an organ donor. And you can also have other comorbidities. You might have diabetes, type 2 diabetes, type 1. You might have other health issues or chronic conditions, but that does not preclude you from registering nor becoming a donor. There are many conditions that we can work with.
That's fantastic. I want to take a little bit of a pause and at least identify for people that are on the call or on the webinar and they're going through what's going through their mind as it went through mine. What is the organ donation process and how does it happen? It was a little bit of a learning curve for me, even as a doctor, to know, because a lot of what we get is from movies and TV. So I want to actually bring it down to reality. So I want to make sure that we all have been around organ donation. So I want to take a step back and bring Erin over to the conversation. Erin, can you share with us a little bit what can you tell us? And Erin is a manager of donor allocation. So share with the audience, how does organ donation happen?
Well, first of all, thank you for having me in the conversation. I really appreciate being a part of this group. And yes, my name's Aaron Cohen. I'm the manager of donor allocation. And gosh, I feel like I'm about to give the speech that I give every interviewee for one of the positions that we have, the donor allocation coordinator. But the
I still need
process,
it. I still need that information. I'm 37 now as opposed to 30. So always need to be educated.
all right,
Very much
well,
so.
well, here we go. Hold on for the ride. So my primary focus is on the deceased donor side of allocation, of donation. Nina, you are a living donor. You made the choice to donate. Deceased donors are those who, their lives have ended. They've are at the hospital. They have been declared dead by neurological criteria. Most people know that as brain death, or their family has decided that, based on their condition, they've decided to discontinue care. Those donors can become what are known as DCD, donation after cardiac death. But that is the pathway for deceased donor donation. OneLegacy and the other 57 OPOs in the United States partner with every single hospital in the entire nation. And the process, it's fairly simple if you look at it in these terms. The hospitals are required to report every death and every imminent death to their local OPO, Organ Procurement Organization. OneLegacy is the one here in Southern California. And it's OneLegacy and every other OPO's job to assess every last one of those reports to determine if those patients are potential candidates for donation. Those patients don't have to be registered, and the hospital has to call in everything from, a newborn death to a person who walked, the 102-year-old person who dies in the hospital. They're required to report everything. The OPO works with tissue banks as well for the donation of bone, skin, corneas, and other tissues that can be used in transplantation. And the OPOs assess each one of those referrals for their potential for organ donation. Once we've assessed, that's when we determine, okay, this looks like a potential candidate. Then we look at what are the family dynamics. Is this person a registered donor? If they're a registered donor, we reach out to the family to walk them through the next steps of the process to honor their loved one's wish to donate. If they're not a registered donor, we approach the family and offer them the opportunity to donate at that time. Once we walk them through and help them understand, we're going to help them with the next steps, or they say yes to donation in the non-registered donor case. We proceed forward with our evaluation of, much more in-depth clinical evaluation of the individual organs. We have a very clinical staff who's there at the hospital. They partner with the nurses and doctors in the ICUs to manage those donors to the point where their organs are as viable as they could possibly be, in order to maximize the donation that can occur from each individual donor. That's where my team comes in after that. We're the allocation team. Actually, a few of them are on the call in the audience. Hey guys. Our job is to locate recipients for each organ that we plan to allocate from the donor. So kidney, liver, heart, lung, pancreas, intestine. We interface with the system that is ran by UNOS, as Brianna mentioned earlier. It's called DonorNet. And that system is what creates the list. When people say I'm on the list, it means they're listed for donation. But each individual donor creates a separate list of potential recipients. So in the case of the HOPE Act, when OneLegacy assesses a potential donor that is HIV positive, we work with the family. We proceed forward with our clinical management of the donor. When we run a list, that list has a special set of candidates on it that are all HIV positive. And that's what the HOPE Act has done. Those patients now have access to this new set of organs that they never had access to before. And it gives them, they are able to get off the wait list much faster because now they're sitting right at the top of the list instead of waiting behind everyone else who, all the rest of the 10,000, 40,000 patients on the list that may have higher priority than them because they are not HIV positive or they've been waiting longer. And so our team we allocate those lists, and to keep it simple, you start at the top, you offer the first one in line. If their surgeon says this organ's not a right fit for this patient, we go to the next one, and then the next one, and then the next one, until a surgeon and their team accepts an organ for that individual patient. And then after all the organs are accepted, the surgeons come to the hospital, they recover the organs and go back and save the lives of the patients that are waiting for those life-saving transplants. So I know I made it kind of simple, it was a little long-winded, but I try to simplify it to the point of it starts with the referral, and I do want to focus in on that section really quickly. The hospitals partner with the OPOs, and it's very important. And when the HOPE Act first came out, you have to remember free donation has been happening for years. And for years, it was automatic. Oh, donor has HIV, close it. Not the patient has HIV, not a candidate. So there was a lot of education in 2013 when the HOPE Act was passed, that OPOs had to partner with our hospital systems for all of us to unlearn what we knew. It became just second nature to just tell the hospital, oh, as soon as they're reporting death, oh, HIV positive, oh, well, thank you. At this time, the patient's not an eligible candidate for donation. So OPO staff had to unlearn that, and the hospital staff had to unlearn. But to credit the hospitals never stopped referring. They've always done their job. They've referred every single candidate. Now it's just a matter of some of these candidates are now, there's more eligibility in the candidates that are being referred. I'll stop there.
Really quickly, Aaron, I did want to shout you all out in particular. Only about 64% of the OPOs in the country are participating in the HOPE Act. The rest are still ruling out based on HIV status. So in Southern California, you all are really lucky to have an OPO that is aggressively pursuing every donation opportunity. And about 30% of OPOs have not yet educated their hospitals about referring HIV positive patients. So what you all are doing is special and it's important, and OneLegacy is doing a great job at it. So I wanted to put those two things out there. We have a ways to go before full implementation of the HOPE Act, and the fact that OneLegacy is making donation happen at every available opportunity is really special and something your team and your ambassadors should be proud of.
You know, Brianna, we try to, I'm sorry to interrupt, we try to make a HOPE Act donor not special. We want it just to be a donor.
It's a donor.
That is a goal.
It's not, yeah. And so we have a process in place, the referral from the hospital, our assessment, and now that assessment just includes ruling in instead of ruling out.
That's right.
So,
and you guys page me. I love to hear from that OneLegacy team. And any of those allocation folks out there, I've been talking to you guys. You tell your team. We've had some cases lately where you all we're serving families and communities so beautifully. The other thing I wanted to say, Aaron, really quickly, and I think Nina has a good question coming up, is just that, as you pointed out, people living with HIV waited longer and were more likely to die waiting. So that's why the HOPE Act it's not a special, sometimes people are like, oh, is this a special advantage? It's actually remediating a disparity. It's, as you were talking about, like, it's so important that these candidates may have waited longer. They did. People living with HIV waited longer, were more likely to die waiting on the list. And by giving them access to an additional donor pool, we're helping them not have that disparity in care.
And some of them don't even get referred to transplant in a timely manner because so many physicians still don't think that HIV and transplantation are compatible. And I think permission to say the quiet part out loud, I think when it comes to HIV positive donors, so many clinicians don't believe that organs coming from donors diagnosed with HIV, whether they're living or deceased, are not healthy organs or organs that are suitable for transplantation. And we're not saying, that correct me if I'm wrong, Aaron, but we're not saying, oh, just because it comes from a donor, we're going to transplant it. It still goes through the same kind of organ evaluation, donor evaluation as anybody else who's not, or who has passed away, who has not been diagnosed with HIV, correct?
Absolutely correct. The only difference is that that donor happened to have HIV. Other than that, everything else is the same.
I want to give a shout out to Linda. She is one of our Q&A participants, and she is an ambassador with OneLegacy. She underwent a live donor liver transplant, and had HIV from artificial insemination. And she's proudly now 20 years post-transplant, yay, and 35 years post-insult from HIV. So she is in California and she knows the struggle that goes in California. But I want to direct a question to a conversation with Nina about Ginny. And Ginny is asking, what are the stigmas that HIV, people living with HIV face most commonly, and how can we counteract them when we talk about things like organ donation and the HOPE Act? And I want to start the conversation by a beautiful quote you said the other day, which is that people do not harm others by donating HIV organs. So I'll get started the conversation with that.
Sure. What I think people in its most simplest form, stigma is a way to create distance. And so the more stigma there came out about HIV in the 1980s, you know, we wanted to place distance between, it's human nature. If you see something that doesn't look attractive or something that's desirable, so like you put distance between yourself by talking about people as far from you as possible. So with HIV, the way that HIV is acquired in most cases is through sexual contact. There's a lot of difficulty in discussing sexuality in this country. People living with HIV are seen as dirty and things like that. And it's 2020, so it's been a long time. A lot of science has happened. We have a lot of medications to treat it. Somebody who's diagnosed with HIV in their 20s can live a normal lifespan with HIV if they get access to healthcare and are on effective treatment. But for some reason, this stigma persists, and HIV itself is a stigmatized topic. I know you all know that organ donation is a stigmatized topic. So one of the, besides wanting to help a friend who unfortunately died waiting for a kidney, so I proceeded to help somebody else because there was no shortage of need, as Brianna was talking about. I wanted to show people, it was 2019 when I donated, so it's 2019. This is where we are with medicine. This is where we are with HIV. And I really just wanted to kick stigma in the rear a little bit, because people are still, especially where I live in Georgia, still thinking of HIV in terms of 1987 and that you have to look sick. I mean, I've run 5 half marathons, 1.8 full marathons. The 0.8 was with the 1 kidney, but it's because it was a monsoon the day of Marine Corps Marathon last year. So it's not the kidney was fine. The kidney worked like a champ, the remaining one. So it's just continually putting these messages out there. If you hear something that's odd, like, oh, is somebody living with HIV eligible for a transplant from a donor whose organ does not have HIV? See, that's an opportunity there to say, why are you asking that? Are you asking that because you think a kidney from a donor who's diagnosed with HIV is any less suitable for transplant? Because that's not correct. That's when you see it, you have to say something to it. And that's how we confront stigma with HIV and also organ transplantation. There are a lot of misconceptions that still persist.
I think all of us that have seen stigma in one way or the other, whether because we have a different name like mine, or because somebody is working in a place or an environment where there's only one gender that is prevalent, whether it is in a office setting where there's more male predominance, or in healthcare where a male nurse is coming into a female predominance. You come to a place where perhaps there is a different ethnicity. We all have had our ways of looking through it and seeing the prism of stigma. And I love what you said, which is find the opportunity. Whenever you hear a question, not ignoring it may not be helpful, because you may educate somebody. And what's at stake is saving not just one life, but up to 8, 10 lives, and providing up to 30 years of life to different people. I met this wonderful man who was a heart transplant recipient, and he had a 5-year-old son, and his wife had died. He's a young father. He's taking care of his son and had a congenital heart problem. And he was actively looking for someone to adopt his son. And he was saving little by little just to leave his son something and making videos until he got a new heart and a new lease on life, both for him and his son. When you hear stories like this, you cannot help but wonder, is it not worth it to take that few minutes and talk to somebody about not just organ donation, but expanding the possibilities for people that are willing to donate their organs? I want to circle back to Nomi, who asked that I understand that people waiting for organs have to meet a financial requirement. And is that still the case? And is that true for other countries? And I'll chime in with Aaron, but as a physician, what I understand in terms of organ transplant is that we just want to make sure that the person who is going to receive that organ has a support system rather than a financial requirement. You don't want somebody who now is going home after a big surgery and a lot of medications and follow up to not have a support system that can take them to their appointments, or make sure that they are well fed, or if they're not feeling well that day, that they take care of things for them. Correct me if I'm wrong, Aaron.
No, you're absolutely right on that. There's a process in the transplant center called selection, where they do have to select candidates based upon their ability to have social support, be able to maintain their medication regimen. And I was looking up the numbers, Brianna. You asked Brianna earlier how many people are waiting for an organ. If you go to unos.org at this point in time, it's 109,000. There's not 109,000 transplants that will occur this year. And so that selection process needs to occur, because they need to make sure that each gift that is donated is going to go to someone that's going to take care of it and maintain it as long as possible. So the question about the finance part, you hit it right on the nail.
I did want to also, from a personal perspective, when people hear HIV, they associate it automatically with the LGBTQ community. And from my perspective, I want to just say, HIV diagnosis, if after 3 decades of research and education and finding out about this, we haven't learned that that is something that can affect anyone, not just through a sexual preference, but also through either a blood transfusion or surgery, or maybe injury, or they are healthcare workers that got stuck while caring for somebody with HIV. I mean, the causes are endless, but what we want to approach this is, just like anyone doesn't want to be looked at as the way given medical care by the way they look, or by the way they sound, or by the way they're dressed. The LGBTQ community does not want to be associated only with HIV. Not that there's anything wrong with it, but the HIV diagnosis itself, and people living with HIV feel perhaps that they do not want to be defined as LGBTQ, but as just a diagnosis that requires medical care. So in my practice, I strive to communicate to people that perhaps saying HIV infected is no longer accepted. It's someone who lives with HIV, much like someone who lives with diabetes, or someone that lives with schizophrenia, or someone that lives with being mentally unwell, and so on. And then, when we are discussing it with others, just as we have our own interests that we want people to recognize, we want to make sure that we recognize the interests of others and advocate for them, even if we may not be. So just because I do not live with HIV, I lived with, friends and other people that live with HIV. So I want to advocate for them when the opportunity arises. Nina, from your experience, what change would you like to see in the world besides just Harry Potter wand and make coronavirus go away?
I want to thank you for acknowledging that I don't live in a vacuum. Like I'm a friend to people. I'm someone's daughter. I'm someone's sister, et cetera, et cetera. And I think what people don't realize is that, one of the ways that HIV is transmitted is sexually, and the LGBTQ community is not alone in having sex as part of a chronic life behavior. So, HIV is transmitted through certain enumerated activities, and, anyone who partakes in those activities has to weigh the risk of doing that and take preventive measures as they are able and are educated and empowered to do. So I just want to say thank you for that. I am a person living with HIV, but I'm also a public health analyst. I am a media person. I used to work for CDC in the Division of Sexually Transmitted Diseases. Right now I work as a health services researcher. So I do all of these other things besides have HIV and besides donated a kidney. And this is true for every person living with HIV. And I think the more that we can stress that, the easier it is for people to care about people living with HIV, instead of just saying that person's HIV infected, because what you're doing in that moment is emphasizing the disease that they have, not who they are. So
Nina, I'd just like to add that you're my children's Miss Nina, and you dress up like a unicorn and send them funny pictures, and you come and chill and eat pad thai with us. So you are a multifaceted person. And I think it's also important for the ambassadors and for the people listening live, just you and Dr. B have described using person first language. And I think that that's really important to do. Like, I'm a person first. It's why, even saying things like, oh, that's a cancer patient. Well, that's a person who is living with cancer right now, right? Like, who is in treatment for cancer. They're not a cancer patient, if that makes sense. So leading with who the person is first. We aren't, shout out to anyone out there on high blood pressure medication. Like, we're not all like the things that, we live with. We're people. And then these are layers to who we are. Dr. B, does that work for you as a clinician who cares for patients every day?
It does. When I walk in to see a patient in a room, they don't want me to look at them as a diagnosis. I ask about, do they like the Golden Girls? Do they watch football on Sunday? Do they like to barbecue? I want to know the human being. And so nobody wants to be, summarized into a one fact in their life. So thank you, Nina. But I did want to at least say that people living with HIV have a predominance of certain conditions that they now have been diagnosed with, now that thankfully they're able to live a normal life like everybody else, which is they have more perhaps renal disease than somebody else. And my friend Jeff Taylor is on the Q&A participants. We talked before about that, they also have a predilection of COPD. They have a variety of inflammatory conditions and so on. So we want to make sure that we do not have disparities in taking care of patients with a specific condition that may make them more likely to have a need for organ donation, yet they are, prevented from getting it because of perhaps an act that now has changed, thankfully, in 2013, but previously from the 80s, when at that time we did not know much about HIV, but 30 years later, we know so much more. I want to perhaps ask Brianna and maybe Aaron to speak a little bit about what do you see in terms of disparities and systemic issues with certain groups in terms of needing organ transplant, but maybe not having access to them?
Sure. Aaron, I'll take a quick swing and then hand it over to you. Does that work?
Absolutely.
Also, huge fan of the Golden Girls. So, I love you, Dr. B. I am not a Blanche, but I'm a Blanche in my dreams. I think a couple of things are happening. As I mentioned earlier, talking about people getting listed, getting access to organ transplant is not fair across the country. And it's just like other, anything else in healthcare. We overserve some people and underserve others, right? And I know Nina has has experienced this and researched this herself in her own professional life as well. But the true need for people living with HIV to access transplant, part of the problem is right now at some centers, they may not be listed at all, as Nina alluded to. And they may not live within a reasonable geographic distance of a place that would list them. So one of the Hope advocates nationally, his name is Gary Garcia, he tells a really beautiful story about going to his transplant center after experiencing sudden liver failure, and saying like, hey, I have this condition, this happened really quickly, the doctors referred me to a hepatologist, right, into transplant, and the doctor at the center said, yeah, but you're HIV positive, so you need to go home and get your affairs in order because we don't list you. And that part of the problem right now is that not everyone living with HIV who is experiencing end-stage organ failure can access a center that will list just HIV positive or people living with HIV as transplant candidates. And then can we expand Hope to more protocols? So I'm about to kick it to you, Erin, get ready. But I see Jeff asking in the questions, what are the barriers to other centers consenting patients to Hope research protocols? Great question, Jeff. One is that any research protocol takes time, right, to have your IRB, to go through all of those things. Hopkins is the coordinating site, though, so we can take some of that off your plate. You'll see coming out next week in the American Journal of Transplantation, the results of the first national kidney trial. So keep your eye on the AJT in the coming weeks. But there's expenses. There's also risk of transplant centers saying, we don't have a specialized transplant infectious disease doctor, which Dr. B, you would know, like that is a subspecialty that is not in every hospital or in every program. But what we hope to see is that the Secretary of HHS, his name is Secretary Azar, Alex Azar, he can say this doesn't have to happen under research anymore. So when he makes that decision, that determination as the HHS Secretary, then many more centers will be able to just list a patient and also access, like Erin described to you, the list of Hope donors, right? The people who come up as a potential donor for them as candidates, because they won't have to have an independent research protocol. It will show that it enters standard medical practice to be able to provide a person living with HIV who's in end-stage organ failure with the potential for an organ from an HIV positive deceased or living donor.
Brianna, you covered almost all of it. And from the OPO perspective, our sole mission, our sole job is to maximize the number of organs available to give those who have access to transplant a chance for the transplant. The one thing I can add is that one of the barriers of access to transplant, it's multifaceted. You said as you mentioned, it's geographic. Are you close enough to a transplant center? One of the more disheartening things I've learned about access to transplant is education, and follow through. You go to the first appointment and the forms just look too overwhelming, and then the person never goes back for the next appointment just to even get themselves listed. And so there's a big push by a lot of transplant centers to try to help ease those processes, make things electronic, make things not as complicated to understand, because it's hard enough just to go schedule yourself for a physical. Scheduling yourself for all the appointments it takes to get listed can be quite daunting for individuals. There's another question here I want to answer at this time is when I mentioned the list being generated, a question here is, the list is currently based on which OPO the person is from. That is correct. So if a donor is occurring in a hospital in OneLegacy service area, we'll use the hospital UCLA, for example. Let's just say the donor is there. Then the list will be based upon how the UNOS rules are put together to allocate to individuals for each organ. So for instance, with kidneys, at this time, kidneys start off with all the patients within local proximity and within OneLegacy's DSA, and then it expands out to a certain region and then expands to the nation. In December of 2020, that'll change, and every organ system has undergone a tremendous change in the way allocation occurs, where geographic barriers are being broken down and organs are able to be shared through organ offers to a much larger area of individuals. So it's already happened with liver, it's happened with lung, it's happened with heart, and kidney's the last one to make that change. But kidneys, I can say, with the HOPE Act, there are not that many transplant centers involved, and Brianna can attest to this. So when
I can attest to it too. There's only a certain number of transplant centers I could go to as a living donor.
Yeah.
So we're gonna try and change that with this webinar.
That's so right, and they're mostly on the East Coast.
Yeah, our OneLegacy donor, those kidneys, if the recipients end up first in line on the East Coast, then we ship them to the East Coast. But as you said, Brianna, once the research label is taken off and more centers become more comfortable with it, it'll be the floodgates will open.
Thank you, everybody. This is enlightening in terms of all of the barriers that are existing and how much work goes underground just with all of us in order for us to change one bit at a time. There is something that's near and dear to my heart, which is before I even went to med school and then in medical school and then in training as a practicing physician, again, like what we said before, I never wanted to be known as the gay doctor. I wanted to be known as the doctor who happens to be gay. But as a person who wanted to help out, I was shocked to not be able to donate blood because I was gay and because of a gay lifestyle. And though this is still sort of anchored in beliefs that are in the 80s, there is also a misconception in terms of the gay lifestyle precluding you from giving the gift of life, whether it's bone marrow, whether it's transplant, or whether it's blood, just because of that. And I wanted to open the discussion in terms of, is it the same? What's happening to the organ donation? Is it happening in bone marrow donation or in tissue donation in terms of just cornea, etc.? So Aaron,
I can answer that. Yeah, I can answer that. So organ donation is actually unique compared to the rest of the donation. Tissue, bone marrow, blood. The regulations surrounding organ donation, we are managed by CMS, whereas tissue donation is regulated by the FDA, as well as blood donation. And the restrictions are a lot tighter on those, in those arenas. In the organ arena, there are certain behaviors that are called PHS, increased risk, Public Health Services Department, increased risk. And the increased risk means increased risk of transmission of Hep C, Hep B, or HIV from donor to recipient. The unique thing about organ donation is that you can have a conversation with your recipient and say, listen, there's an organ. It's a kidney. It's coming from a person who was increased risk for Hep C, or it's coming from a person who has Hep C, or in the case of the HOPE Act, it's coming from a person who has HIV. And the doctor and the patient make a mutual decision to accept that transplant. Whereas in blood donation, tissue donation, the way the mechanism of transplant works, they've put in measures in place to ensure there is zero or minimal transmission of disease from donor to recipient. Whereas in organ, you can go in eyes wide open and just treat the potential transmission of Hep C, or in like we said, in HOPE Act, HIV to HIV persons.
I did want to add, Aaron, they're revising, as I know you know, the PHS risk factors, and those are going to come out very soon. And I just also wanted to say, for the non-clinical folks out there, a good way to think about it is that we used to really concentrate, as Aaron described, on minimizing what we would call donor-derived infection. So the transmission of infection between a donor and a recipient, if maybe we couldn't screen for it in time. And I'm certainly saying this in front of Nina, who has a very specific personal story that involves that kind of a scenario. But what we found is that we got too good at telling people that things were risky without describing to them that their risk of death on the wait list was far higher. And and I've said this to Nina, and Erin, I know I've said it to you, I think when I saw you in LA a few years back, but if someone I loved was in need of a transplant right now, I would look for a way to even consider, if there was a center that would open a protocol for the acceptance of a quote high risk donor, or even a hope donor, because I personally, and for the people that I love, I would say get off the list as soon as possible, and HIV can be managed with a pill a day. That's not where the laws are right now, and that's not where the policy is right now. But I do think there's a world in which, in 10 years, we might be saying, look, HIV is a really manageable condition. If you need a kidney transplant and one comes up from a person living with HIV, would you be willing to accept both the organ, and maybe we can put you on a post-exposure prophylaxis protocol? There has been one positive to negative transplant in the world so far, and that happened in South Africa, where a mother who was undetectable in her viral load provided part of her liver to her child who would have died without a transplant. The child, to our knowledge, has not ever seroconverted to be positive to HIV, which is kind of mind-boggling if you think about it. Dr. B, I know you're nodding. You understand this on a level that I don't, but the mom made a decision, and the physicians made a decision to say this baby's going to die without a liver transplant, put the baby on a prophylaxis protocol, and then gave the child that organ, and the child is not, to our knowledge, living with HIV. That's kind of an incredible thought. And what if in the future we could say the same thing to American patients, to say, if your concern is getting off the list quicker, would you accept an organ from a person living with HIV? And then we'll try a protocol to see if we can prevent seroconversion.
Thank you. I think that this is, every minute I hear every one of you speak, I'm just mind explosion. I want to bring it back to something that is, I'm sure, near and dear to us all, which is a question about how do you educate, quote, minority groups about both HIV issues and transplant registration. I want to start by something basic, which is what we're doing right here is providing the chance. That's all. Nobody who lives with HIV should be denied the chance of an organ transplant, much like somebody who doesn't have an HIV diagnosis is allowed the chance to have organ transplant. If you were to walk into a doctor's office and there's a treatment for something and you were denied that because of an arbitrary rule, that would make you sort of indignant. And that's what we're appealing to, is if you feel like you have a right to being treated for an ailment or an illness or a condition, or at least given the chance to say yes or no, then everybody who has other conditions that you may not have should be able to. In addition to that, I want to also speak to the fact that there are various disparities in terms of several groups just because they did not have a chance in life that other ones did. And we are living in another environment. I started with the environment of COVID, and I want to also bring the other environments of, all of the Black Lives Matter, and calling out that we all should have a chance at everything equally. So some may not have had the chance to a good education or to a good socioeconomic status, or living close to a geographic area that allows you the ability to have, not just organ donation, but transplantation and access to HIV medications and so on and so forth. So I guess if we are to speak to what has been dubbed, in quotes, minority groups, it's to appeal to the fact that we are just all striving to give a chance of equality of access to any therapy, including organ donation. Any panelists would like to chime in on that?
Yeah, I just want to tag on in there. It goes to part of what we were discussing before about, why are we conflating LGBTQ with HIV? And it's because people do that because they see that that's who's most disproportionately affected. And when they see, oh, gay people and people who are minorities are most disproportionately affected about HIV, that's where we get the idea that HIV is a Black and brown person's disease or a gay disease and things like that. So I think obviously our education for HIV prevention has to be with sexual and racial minorities. And with organ transplantation, minorities are at increased risk for end-stage organ failure because of what we call the social determinants of health. Where you live can be dependent on whether you live, what kind of education you get. So even though we try to talk about, not making it about a person, we certainly don't want to be ignorant to the fact that viruses have a predilection for affecting the most marginalized in our society.
Perfect. Speaking of disparities, I want to ask a question that was very important that was asked, which is, how can we increase the health centers that participate into HOPE Act transplant? Brianna, you mentioned in the beginning that we would have up to 60% only of OPOs that actually educate their centers and their physicians. We have a long way to go to work on educating. I will take the ownership of my brethren, physicians. We are the first line. We are the people that develop the rapport with the families that are grieving their loved ones. And I will say that it's not easy because I have, I'm emotionally invested in that patient and I'm trying to save them. And you have to get over your own sense of failure and perhaps spiritual understanding that there may not be anything else to do for this patient, and then carry their family through the 5 stages of grief right away after you establish rapport with them. That is, I trust you with life or death of my loved one. And then when you carry them all through this, you want to give them as much time as they need for that to sink in. But at the same time, if a person is able to donate because of a brain death diagnosis, then the clock is ticking. You don't want those organs to start creating some damage, so you want to do it quickly, but you don't want to do it too quickly. So there is a lot of finesse that has to happen at the bedside, and educate the families and then make them feel like, I know you're emotionally traumatized right now, but I'm speaking to the future you in a year or two that would look back and say, I wish I had known that my loved one's grief would have been tempered by knowing that I could hear their heartbeat in somebody else's chest that now has a new lease of life. Or somebody who, was not able to go travel anywhere because of dialysis. Now they're able to go visit their enlisted son in a different country because now they're able to travel, and so on and so forth. So anything you can chime in from that perspective in terms of organ donation, how can we educate centers that it is okay now to enlist the HOPE Act?
I think a couple of things for me. One is ensuring that patients can advocate for themselves, right? So bottom up education, getting more education out into dialysis centers and also HIV clinics to say, right, if you're an infectious disease doctor or if you're in care, like you should know, right? Like these are the things that can happen. And I think the best and most important thing to share is there's an adequate research base for physicians. So Dr. B, if I'm trying to persuade someone like you, I'm thinking, how can I show him that there is good research that supports, right, the safety and efficacy of transplants for someone in my condition or my loved one? So getting that plain language education out to HIV clinics and to dialysis centers, to me, is the first and best thing we can do. And I think that's the next kind of generation of HOPE Act education, is educate the HIV docs, educate the nephrologists, educate dialysis patients, right?
Sounds
so
like there's an article blast that's going to happen with this forthcoming data coming out from the HOPE
Yes,
team.
there is, Nina Martinez. Yes, there is. So getting that out. And then Dr. B, I think the other thing that if I could wave a magic wand is the pressure on those places where organ donors are still ruled out because of HIV status, that we have, you know, community groups in those places that say, hey, you're not considering us as organ donors, even though we should be. So some of that is getting pressure on those places to say, like, this is the federal law, like, these are the things that we should be, you know, we should have equity and access to organ donation, just like we have equity and access to organ transplantation. So
one quick plug. Nobody in America who is HIV positive and waiting on an organ transplant should be denied transplant solely based on their HIV status. If they are otherwise a candidate for transplantation, meaning they meet all the center's other criteria to be eligible to receive an organ, it is against the Americans with Disabilities Act to use their HIV positive status as a reason to solely deny them transplantation because of it.
I appreciate that. I think I'm going to steal one liner from Brianna, which was you had mentioned that this is not an end of life decision. It is a public health decision. I want to thank everybody for chiming in right now. I want to thank everybody for educating me and the public in becoming fluent in the HOPE Act and in organ donation. I hope that if we have changed one mind today, that what we're doing is just give an equal chance to everybody, regardless of what they have and who they are and what diagnosis they carry, then we would have done our job. I want to toss it back to Tiffany, if you can chime in and let us know how can we best educate and how can we best move this forward.
Absolutely. Thank you all for this wonderful conversation. There's so much we can continue to talk about, and the conversation doesn't stop here. So although our time here must end, we will continue to connect the dots and keep important conversations like the HOPE Act and others at the forefront. Thank you, Dr. B, Brianna, Nina, Aaron, for sharing and educating our community. And to everyone that's on here, thank you for joining to hear what these professionals and experts have to say. And so before I wrap up, I just want to say that this platform, please be reminded that this platform was created for you. This platform is to hear from you. We want to engage with you. And we want to make sure that we are providing tools and education that are essential for our communities to thrive. So if there are any future suggestions or topics, please feel free to submit them. And please don't forget to discuss the importance of organ, eye, and tissue donation with your families. Until next time, we'll see you on Connecting the Dots.